And
Good
we are live.
afternoon. Good afternoon, and welcome to the February 2024 session of Arizona Community Grand Rounds. My name is Mark Carroll, and I'm with Blue Cross Blue Shield of Arizona Health Choice, and I'm pleased to facilitate today's session, which, as you can see on the opening slide that we're presenting for you today, is an update on long COVID emerging evidence. Before I introduce today's guest and expert in this subject that we're so pleased to have with us today, just a few general notes about Arizona Community Grand Rounds. These rounds are hosted and supported and organized by an important and valued collaboration of the NARB Institute and Blue Cross Blue Shield of Arizona. I'd like to offer special thanks to Mary Jo Gregory, CEO and President of the NARB Institute, to Carla Berg and Jessica Rigler and Jennifer Pierce and others with Blue Cross Blue Shield of Arizona. Rounds are offered typically on the first Wednesday of the month. If you stick around for the entire session, we'll tell you about the rounds coming up in March and April, where we have two great sessions planned for the spring of this year. Rounds are recorded, and there'll be a link that'll be posted in the chat by Jennifer. Thanks, Jen. During the session about where you can go and see a recording of this session, as well as previous sessions that we've had. CMECEs are applied for, have been available last year. We expect them this year, and there'll be information at the end about how to access them if you'd like to. Any questions you have during today's session, please feel free to put them into the Q&A, and we'll get to them hopefully during the course of the conversation today. But we're pleased to be joined today by Dr. Sairam Parthasarathy. And Sai is a colleague and friend that I've gotten to know in recent years. He is a repeat guest on Arizona Community Grand Rounds. Sai, I've been so thankful and appreciative of your expertise that we're so thankful to have you back today on this topic. As noted by way of brief background on Sai's very impressive long bio, he's a professor of medicine and the chief of the Division of Pulmonary, Allergy, Critical Care, and Sleep Medicine at the University of Arizona College of Medicine, as well as the Murray and Clara Walker Endowed Chair for Emphysema at the U of A's College of Medicine. Sai also chairs Pulmonary Clinical Consensus Group for Banner Healthcare System, director of the Center for Sleep and Circadian Sciences, and does many other things, some of which you're going to hear about today related to long COVID, and quite impressive work. One last note that there are no disclosures to share related to today's session. So today's session will be a conversation with Sai and myself, which is a real joy for me to have with you, Sai. So welcome, and we're pleased you're here today.
Thanks, Mark. It's a pleasure to be here. I appreciate the opportunity.
So can you first start? There are a lot of questions. There's a lot we could talk about in long COVID. What's top of mind for you these days?
I worry that we are taking the eye off the ball. I worry with regards to both COVID as well as long COVID. We seem to be a bit globally, it's just maybe my perception, a little blasé about it. There is a 20% chance that in the next 3 years, there could be an Omicron level event. And considering that threat, only 17%, that's 17% of the entire US population is up to date with their COVID boosters. To me, that's a huge paradox. Along with that, it is unclear, just like how we stressed the banks after the 2018 debacle and the economy. It's unclear to me as to whether we've stressed the very same systems that we felt were flagging and not keeping up in terms of the public health reporting system, the PPE availability, the ability to flex up and have the workforce, healthcare workforce to be able to tackle the acute pandemic. It is uncertain whether we have created a robust set of resources and pipelines for us to be able to combat if the pandemic were to happen all over again on the same scale that it did in early part of 2020. that is uncertain. Now, add to that in terms of the long COVID, we are still making new cases of long COVID at a rate of perhaps 10% of infected cases, or maybe less. But at least based on some data that we have with the original, pre-Omicron variants like the Delta and the Beta and the ancestral strains, we were generating a lot, the cases of long COVID at case rate of like 40% of infected cases. But that's dropped in the Omicron era, post-vaccination era, down to about 10%. But again, that's 2 years old worth of data. And we don't know how many new cases of long COVID we're generating at this point in time. I'm in clinic this afternoon, and I heard one of my patients called in saying that she will be she will cancel the appointment because she had COVID. And I have faculty and staff that are calling in sick this week with COVID. And so, yes, it is true that long COVID is not as prevalent as it once was. The CDC Household Pulse Survey put it at around 9.5% 2 years ago, but it is slowly but surely reduced down to about 5.5%. But that's still, or nearly 17 million people in the US that are suffering from this condition. And again, that's based on self-report. It's not based on clinical evaluation. I really think long COVID right now is changing the trajectory of the health of the nation for the worse, right underneath our noses. And we seem to be unaware of it. I think 5 years from now, 10 years from now, we'll look back and know this is the point in time where we departed in the wrong direction for the health of the nation, and we didn't even know it.
Well, boy, that's quite a perspective, and you shared some really important statistics there that maybe we should just revisit briefly. The first, well, they all got my attention, and I'm sure our collective attention today and otherwise. A 20% chance of did you say an Omicron event? In other words, we still have a lot of circulating virus, and how would you define what an event is? You talking about a new variant, or an increase in cases, or a combination?
Yeah, just like with influenza, with the influenza pandemic, as you know, there is this drift and shift, right? If you're drifting, it's okay, but when you shift, you got some major family of flu virus. Similarly, the Omicron was a major shift. It wasn't a drift. But then Omicron is drifting within itself with various subtypes that I can, keep track of it myself, considering that I try to follow this literature closely. And so the latest one is, JN1 or something like that. But, it's drifting. But what if, just like how it shifted from Delta, or Beta to Delta, and Delta did a big number on us across the globe. What if there was a similar shift from Omicron to an entirely new class? And that's where it's concerning. Some data suggests that some of the antivirals, like molnupiravir, seems to propagate the ability of the virus to try and find new mutants. People immunosuppressed and immunocompromised have viral persistence, and those viruses are capable of finding new mutants. And the crazy thing about it that we learned is that some of these mutations, like the South Africa strain, when it happened, the same thing happened in London. And the question is whether people flew from South Africa and London, or did it happen de novo? Was the virus at that particular genetic state that the next particular shift was a major shift? And then it was alarming. And so, and this is a prediction by Tony Fauci, Eric Topol, and Ashish Jha, when he was previously the czar of the COVID coronavirus task force response from the federal government, that this was what they rated as a chance of such an event. And the question is, are we prepared for it? And what are we doing about long COVID that we are generating with every case, every week? People I know who are developing COVID. And why is it that we're taking the eye off the ball with regards to vaccination? We went up to close to 69 to 70% of US population having had the primary vaccination series, which is either 2 shots of the mRNA and 1 shot of the AstraZeneca shot. But The question is, I'm sorry, the J&J shot, but at this point in time, in terms of boosters, people should have had 5 to 6 boosters, or 5 shots essentially at minimum. But only 17% of the nation is up to speed with that. I fear that it is not a focus of attention, and we're worried that we're going to pay the price.
Well, let's follow up on a couple of those really important, not just statistics, but thread of the story around long COVID. First, let's talk about terminology. Is it okay to say long COVID, or should we be still saying PASC, post-acute sequelae of COVID? When we do literature searches, will they be picked up long COVID, or should we be using PASC, PASC? Quick thoughts on that before we go back to where the topics you were just discussing.
Yeah, that's a great question. I want to say long COVID is more commonly used than PASC. PASC is the more scientifically accurate term. Long COVID, the only problem that the scientists have with long COVID as a accepted, scientific definition is that you don't have to have COVID to develop the sequela of the virus infection.
Mm-hmm.
So, the thinking then becomes that, oh, I need to have been really sick with it, been hospitalized or stayed at home for 3-4 days for me to have had COVID, running fevers and whatnot. And then and only then can I develop the sequela, which is long COVID. But the problem is you can have a subclinical viral infection and not really even run a fever, just have a little sniffles or have no symptoms at all, but you're accidentally found to be positive and you were swabbed for whatever reason. And then 2 months later, develop the sequela of that viral infection. And it sort of goes down into why people develop long COVID and their various theories, which I'm sure we'll be talking about. But then those people, the ones who had a subclinical or asymptomatic infection and were lacking symptoms, didn't even know that they had it, will not know that this virus infection actually contributed to their new sickness or ailment.
How do we understand that? First off, some people may be wondering, how do we actually know that? So, and is it because of the evidence of certain types of antibodies and testing that we can determine that?
Yeah, so it gets gnarly, right? In terms of the antibody response, there's the antibody response to the vaccines as well. The concern, so one of the findings from Harvard group that published this study is that we're able to find whole spike protein circulating in the body, in the serum. Not in everybody with long COVID, but in a good portion of them. I would say something to the tune of about 50% of them. There are these whole virus spike protein particles going around. You can have subunit of the various antigens floating around because of the particular vaccine, but not the whole spike protein. It has no business being made and circulating around in someone's plasma if they've not had the infection. And so that means there's virus persistence in the body. And autopsy studies are showing that it's persisting in the body, in various nooks and crannies of our body when we have long COVID. So that becomes a potential biomarker. But we're still in the hunt of a reliable test. There are also tests where you can take T cells and do ex vivo stimulation studies to see what kind of antibody response they have, or T cell assays that can be done in order for us to know whether this is essentially someone who has long COVID, or whether you can try to predict whether someone had an infection or whether their antibody constitution is because of the vaccine response. So you can try to figure out whether someone had a prior infection, but A true biomarker for long COVID is what we're in the hunt for, such as the whole spike protein, but it doesn't seem to catch everybody.
So there's good evidence. It's not perfect evidence, but there's good evidence for the statements, good scientific evidence that a person could get long COVID from a very mild infection and maybe not have an illness. We know that from highly specified testing that you've noted. This is important for me to remind myself, just even as a clinician myself, of what we know so far and what we're looking to learn. And there's evidence that vaccines work and they prevent long COVID, correct?
Yeah. In a recent publication in May of last year, the investigators in the RECOVER study, which is the $1.18 billion investment in looking at long COVID by the current administration, which I'm fortunate to be a part of here in Arizona, we were able to show that people who are vaccinated have a reduced risk of developing long COVID. And even though in that study it was modest, it was about 25%, there's a question about how those participants were selected, because we cherry-picked people with long COVID into the study. They were the hardiest of the most symptomatic people. And so in them, the vaccine may have attenuated the severity of COVID or the onset of COVID or presence of COVID only to a certain extent, because these are case control studies. They're not perfect epidemiological studies where we went and knocked door by door and enrolled participants into it. As a result, we think that some of the effect size or the magnitude of effect may have been diluted. But bottom line, every study that has come out, be it from the US or from from other investigators across the world, they have consistently shown that getting vaccine, and in fact, an Italian study showed a dose response curve. The more shots people got, going from 0 to 3 at that point in time, and they published it in JAMA as a letter to the editor, they showed that going from 0 to 1 to 2 to 3 shots, you're progressively reducing your risk of developing long COVID. So there is any clear way of preventing it is prevent yourself from developing the infection in the first place by getting vaccinated, prevent being hospitalized, and as a consequence, prevent yourself from getting the sequela, which is long COVID.
What advice do you have for folks taking care of other people, as well as making their own decisions around the timing of vaccines? Give an example, and I'm sure there are many of these, and I'm sure you get questions like this pretty regularly. So I appreciate you letting me explore a little bit. So, well, I'll take myself. I've had, I don't know how many, but I've had a lot of vaccines. And I was a no-vid, which I understand means no COVID, or at least aware of being ill and having a COVID illness until last year. And I got hit pretty hard. But I did not develop long COVID. And I then subsequently had the fall vaccine. Am I good? Should someone like that, who I guess I have a mix of now immune protection, but my last vaccination, was 4 months ago or so. Am I good for the season, like the flu shot, or stay tuned, or should I get a boost, or we don't know?
Yeah, at this point in time, the CDC recommendation is an annual shot. So starting with fall, with the bivalent vaccine that you received in the fall of last year, we're headed towards a once-a-year shot, and they're trying to increase adherence and reduce some of the confusion and complexity of figuring out, hey, should I get a shot? Now? Should I get it later, 6 months from now? Or so to reduce the confusion. Wasn't so much evidence-based. It was more based on the fact that, hey, we need to keep everyone immunized. So let's at least go with once a year. But it is true that the antibody response due to a vaccine wanes at about 6 months. And technically, someone should get a booster in 6 months. But the current recommendation is still for a year, because I think there's sort of a wait and watch what happens mode. We also don't want to overwhelm the population saying, go and take 2 shots, every year, every 6 months. Because everyone is on their own little timetable schedule, and their schedule gets upset when they get an infection, because it gets pushed down by 60 days now, and previously it was 90 days. And the recommendation is not to get a shot within 60 days.
So it's 60
that.
days. That's really important. 60 days now. Okay.
Yeah. And in the past, as you know, it was 90 days. And so that gets very confusing. Everybody gets thrown off the schedule. It's also an issue with the inventory. It's also an issue with the tailoring of the mRNA vaccine for what is the du jour strain. So their general agreement was, hey, something that worked with flu, let's go with that. Yes, there will be some infections that will be taking on when we go into once a year. We will be going and exposing some of the people who got the vaccine early in the fall of last year, who may get an infection in, let's say, July of this year, before they're up for the new shot this fall. There is a recognition of that, but it seemed to be outweighed by the confusion we would create and the staggered schedule that we'd create for individuals when they get their schedule postponed by 2 months, when they develop an acute infection, a breakthrough infection, as we'd like to call it. But it is a fact that, maybe the messaging was an issue. Maybe we should have messaged saying that the vaccine doesn't prevent people from developing the infection, but the vaccine prevents people from getting hospitalized or dying from the infection. Because there are some people who say to me, even though I try to champion the vaccine, and they just say right out to me, yeah, I took the shot and I still got the infection. But no, but you didn't get hospitalized, did you? And so they're like, yeah, no, I didn't get hospitalized, but that's not what you folks said. So there is this a little mismatch of expectations. And so it's very important when we're talking about population health that, Mark, you're more than familiar, is that we don't want to stress the population too much or create, higher expectations than what we can deliver, because then we lose the population.
Right.
Lose their faith, faith and belief that this is something that they should be doing. And that has more downsides rather than being perfectly minimized.
Yeah, well, I appreciate your transparency in the conversation, because that faith, that trust, we know is stressed in society in general today. But we'll just talk about specific to medical science and healthcare and issues related to COVID, because that's emerging for us in our understanding, obviously moving forward. So long COVID. So my take home, what you just said, my reminder was, hey, vaccines still are helpful because they prevent me from getting infected, me from getting sick. If I'm infected, I can spread, and either I could develop long COVID still now, or someone that I spread to could. And depending on the statistics, anywhere from 1 to 10 to 1 to 20 people at 1 to 20 people at minimum, but probably closer to 1 to 10 develop long COVID. So talk a little bit about diagnosis of long COVID, the different phenotypes or ways that it presents, and what we know now.
Yeah, I think it would be, somewhat helpful to sort of talk about the various reasons.
Thank you. Yeah, back me up. Go to why. Yeah.
And that'll tie to how they can self-identify. Hospitalization is an absolute risk factor for developing long COVID. If people got COVID that was, bad enough that put them in the hospital, and right now it's putting people that are immunocompromised, either due to a history of cancer chemotherapy, underlying immune deficiency syndrome, or someone who's a transplant recipient. Those are the people who are at greater chance of despite being vaccinated, getting sick enough that they would get into the hospital. Of course, if they're not vaccinated, we still get a few of those that end up in the hospital. By virtue of the fact that they're hospitalized means the infection was so severe that it overwhelmingly damaged their organ systems. It can damage the lungs, it can damage the various organ systems, and as a result, the brain, and so on and so forth. And as a result, these organs take time for them to heal. And so 30 days out, which is the definition of long COVID, is persistent symptoms more than 30 days or 4 weeks. You want to be precise, 28 days. So on the 29th day, someone who still has a hacking cough or a problem that they had before that's worse now. Let's say they had asthma before in the past. It is known that SARS-CoV-2, just like any other viral infection, can exacerbate the asthma. Of course, they get into the hospital because of that. And then 28 days out, the asthma is still giving them a hard time. Now, by definition, since the underlying medical condition is worse now than it was before, they do have long COVID because they have a sequela that was left behind. Now, RSV can do that, but so can SARS-CoV-2. But in some cases, they can have an underlying lung issue. And so that's when they need to seek medical attention because it's not going away like that long lingering cold that an asthmatic would have after 4 weeks and beyond. And so I use the example of asthma because I know there's a question regarding that, and to say that, yes, they are predisposed to developing that. Now, that is a plain and simple way of saying that if someone has a severe infection, they have a sequela because of the organ damage, and then therefore they have a problem. And if they had an organ damage or organ problem to begin with, such as asthma or COPD, they're more likely to have the respiratory complications more than 4 weeks out, and therefore they have long COVID. You can treat it as COPD and asthma, but there they can get into a false sense of security if there was indeed truly a lung issue going on. For example, there are some people who develop bronchiolitis obliterans, organizing pneumonia. It's essentially an exuberant response of the lung. It's almost like a keloid scar that we develop. We can get a wound and it can heal nicely without a blemish, or it can have an exuberant scar to form a keloid scar. Similarly, the lungs can have an exuberant scarring and fibrotic response called organizing pneumonia. And so if someone says, well, this is just my asthma and I'm not going to seek medical attention, it can be a problem. It can continue to worsen. And only by doing an X-ray and a CAT scan will we know that it's something different. Or is it simply the asthma that was worsened as a long COVID manifestation? We just need to step up on the asthma treatment so that we can get rid of this. That's a question. So that is a simplistic explanation for why anybody would develop long COVID. But there are 3 other running theories. One is this virus persistence. It specifically happen in people with immunocompromised state. Like I said, the virus can be isolated in bone marrow, in the intestinal wall epithelium, in the dura mater of the lining of the brain, in even the vitreous humor of the eye, in autopsy studies where replicant competent viruses. In other words, we can take those viruses and we can make them replicate in a petri dish and show that these viruses are alive rather than remnant particles that are just sitting embedded in this tissue. And so these are viruses that can replicate and are capable of replicating and being viable. And so we are finding that the virus persistence theory is an important one. And who are the people who develop that? Those are the people with an immune system that's not up to snuff. They have immune dysregulation. They have an immune system that's not robust enough. And they are usually the ones with the immunocompromised problem. And so, and in those people, you would argue that the immune system needs a boost, that we need to rev up the immune system in order to fight, or maybe give an antiviral to fight it. So you see how the cause of the long COVID is also speaking to what should be the treatment. Time may be a tincture, or giving steroids for the exuberant scar may be a treatment, or some specific anti-inflammatory agent to reduce that inflammation. Or it could be something like this, where we are talking about beating up on the virus that's still persisting by either revving up the immune system by giving vaccine shots, or giving other immune approaches, or by giving an antiviral, such as Paxlovid, for people with long COVID. The other prevailing theory is a dysregulated immune response where there's an autoimmune response. And so that's why we find that a lot of people with underlying autoimmune conditions like lupus, rheumatoid arthritis, Crohn's disease, things like that, are more likely to develop long COVID. That's because the immune system in them has a difficulty recognizing self from non-self, and it starts attacking normal tissue that was instigated by this virus that when it sat next to normal tissue and made the normal tissue look foreign, so our immune system starts rejecting or attacking it. And that's what develops in, as a pop issue in people with autoimmune syndrome. And in this particular situation, it can actually aggravate that because of the SARS-CoV-2 infection, creating that situation. In those people, we have to give, again, some anti-inflammatory agents. So should we be giving steroids? Should we be giving monoclonal antibodies? Those are all questions that are emerging at this point in time. And the other thing we're finding is that there is something called gut dysbiosis. The gut bacteria are changing in nature and are altered, and that leads to dysregulated health. Because normally we have a kilogram, of bacteria in our gut that is essentially very important for how our immune system works, how our body works, and it's actually they are actually commensals living with us that are responsible for our good health. In their absence, or if they're changed in their flora and fauna, when that happens, we have immune dysregulation, we have problems, which lead to symptoms of, long COVID. There are even studies which are looking at transplants of bacteria by trying to change the gut dysbiosis and trying to improve long COVID symptomatology. And then the last thing I want to say is that the blood clotting capability is, again, affected. And so people who can have an asymptomatic SARS-CoV-2 infection, the next 2 months, 3 months, they're still at increased risk for developing blood clots. If there's some other problem, like, if they go on a long flight to Australia, or something like that, but then their blood is already a little bit more coagulable, they have a family history of clot formation, they have the correct or wrong genetics for it, and then kaboom, because of this infection, it does increase the risk of developing clot formation. Now, you would think that that's not long COVID. Hey, I just developed a clot. No, but that clot formation was instigated by the SARS-CoV-2 infection. Is one of the other manifestations of long COVID. So there, we had to give them blood thinning agents, and so the treatment there differs based on the cost. So that also sort of describes to you the phenotypes. But if I were to put the phenotypes, some of the broad phenotypes or presentations are people with severe fatigue and what we call post-exertional malaise, where they just go, they're doing fine sitting, but then they just go get the mail and come back home and come back into the house, literally walk 20 feet this way, that way. And now they're exhausted enough that they actually need to take a nap. And so there is this chronic fatigue syndrome and meningoencephalitis overlap, or ME/CFS, with these people with fatigue and post-exertional malaise. The other symptomatology is POTS, where they have dysautonomia, where, when they stand up, they, have this tachycardia that's not explained by a drop in blood pressure. In some people with long COVID, we find that there is a drop in blood pressure, not because they're dehydrated, but their autonomic system is not regulating itself well. It's not the same dysautonomia as was described previously. So there's a lot of controversy going on. So is this POTS or is it not? I would just say that the long COVID version of POTS is maybe different than the previous POTS that we know. Nothing to take away from dysautonomia and POTS previously that were defined, but this is a new variant of that. We should still treat them.
And
then there are people,
POTS meaning
yeah,
postural orthostatic tachycardia syndrome, terrible acronym, POTS. I'm sure many people watching are familiar with that.
Yes, thanks for clarifying that, Mark. Yes, it's partial orthostatic tachycardia syndrome, and where they can feel dizziness and palpitations when they suddenly sit up from a lying down position or suddenly stand up from a sitting position, and can also have unsteady gait and have to catch onto walls when they're walking because they have such difficulty with being able to hold their erect posture. And then there are people with sleep problems. There are people with insomnia where they can't sleep at all, or difficult falling asleep, staying asleep, early morning awakening, or they have excessive daytime sleepiness. where they're sleeping excessively. So sleep is another significant problem that can be crippling for these individuals, and they're unable to hold their jobs and do the normal day-to-day activities because of that. And then there are people with a respiratory manifestation, a cardiopulmonary manifestation, where they're short of breath, they are dragging an oxygen tank along, either due to the severe disease they had in the hospital, or this condition we were talking about, like organizing pneumonia, or worsening of asthma, worsening of underlying COPD that they had before they went in with wheezing and shortness of breath and chronic cough. These are very common manifestations in terms of the respiratory manifestations, because after all, the SARS-CoV-2 infection is a pulmonary infection, and that's where it starts. And then one of the things that we worry that is also very common is brain fog, where people find that their mental acuity is not a shock. They have difficulty finding words. They forget where they park. I had a woman in her mid-40s who says that ever since this happened, she can't hold a job, and she doesn't know where she parked her car when she goes into a grocery store, and she has to search for it. She forgets her keys. It's someone in the mid-40s. And so we find that high-functioning people who work for some really, top jobs are finding that they need to find a different job now. They're not able to keep pace. So very concerning. Now, with all of these, there are some things like respiratory that may get better, but there is a worry, and Eric Topol, wrote a very nice article about this, is that the worry is that some of these conditions, especially neurological ones, such as having neuropathy, there are a total of 96 symptoms that have been attributed to long COVID. We can't get through all of them
96.
today.
Wow.
96. Which is being all researched and being collected as part of the Recur study, and we just kept adding more and more of these symptomatologies as we kept discovering new ones. For example, menstrual irregularities is a well-described long COVID problem, where people have dysmenorrhea and end up developing iron deficiency and developing restless legs and developing insomnia. And they come in. So these are all dots that are connecting to each other. And so having a heightened sense of awareness that these are all the symptomatologies that can be caused by long COVID, A. B, connecting anybody who presents as a new patient in clinic with a new problem, trying to see if that is in any shape or form connected to a recent or a past SARS-CoV-2 infection is very important, because as they say, the eyes don't see what the mind doesn't know. If we are not knowing that these are all connected dots, and we don't ask, hey, you have this problem that you're seeing me, for the reason why you're seeing me today. Now, when was the last time you had COVID? Did you have COVID at all? When was the last time you had it? And did this problem start right after that? Very simple question, but you'd be surprised that that's not something that's being asked.
Do you think sometimes it's because, and there are a couple of questions that we'll get to that a few of our participants and listeners have sent in. So just bear with us a sec, because they're going to take us in some different directions in the conversation. Do you think people aren't asking because they're just not sure what they're going to do with that information? In other words, there's not a reliable biomarker test to tell me long COVID or not. And then therapies are less clear. And I suspect you agree with that. So maybe update on, well, what do we know about, where are we with biomarker testing? You've already talked about some previous evidence. There's a lot of conversation recent months around coagulation state biomarkers and a constellation of them in protein testing that was highly reliable in some data that I saw in some published articles. But also the therapies are evolving, like where's Paxlovid? And what about some other therapies? So what are your thoughts around, okay, why should if I ask clinically and someone says yes, what do I do with that information? Do I have therapies available? Is there particular testing? And other clinics that are specializing in long COVID? So those are three-part questions for our next part of the conversation.
Yeah, I mean, they should take action on this, partly because it gets to the bottom of what is ailing them. Sometimes the treatment is very similar. And if they do not have the moniker or the diagnostic label of long COVID, such as, let's say, with asthma, which can be exacerbated in people with long COVID, the treatment would be very similar to someone with asthma exacerbation that had nothing to do with long COVID. So there, one is okay. But let's say if the problem was due to persistent virus particles and viruses in their body, and Paxlovid, treatment can set them on the right treatment trajectory where it's taken care for good, rather than it keep, arising over and over again. And for that particular medical issue that they have, for it to, exacerbate and wax and wane and wax and wane, which is what we're seeing, because there is a study where we're trying to look at the trajectory of the symptomatology, because we know that there's a waxing and waning going on. So yes, there's the tincture of time, but what if the virus was persistent in these people? What if it's going to cause some blood clotting problem that you refer to that can actually threaten their life, where the clot can actually stop the heart?
Can it cause cardiac? Can it cause a heart attack, a myocardial infarction? Someone asked that question.
That is something we're trying to answer the question. The fact that it causes clot formation in the legs, in the deep veins of the hips, that can go into the lungs and stop the heart and cause essentially a cardiac arrest, that has been clearly shown. However, whether it can increase the risk for heart attack, there are studies early on, were studies suggesting that cardiovascular disease is more likely, but we don't know the answer to that question emphatically. And so there is the recovery cohort where there are cardiologists who are essentially looking at that exact same question. But there are studies from various investigators across the world that yes, there is an increased risk for heart attack, but the signal we believe is not as strong. However, we don't know, because teasing out other factors is also a tough one. For example, during the pandemic, people were, not exercising as well. People literally a lot of people we know gain weight.
We're all home and we're in our kitchens. Yeah,
exactly. And our number of step counts dramatically dropped. And so blood pressure went up, and that can increase cardiovascular risk. Now, if you want to attribute that to COVID, you certainly can, but someone even without COVID infection ever could develop that because of changes in behavior and physical activity and diet during the COVID times. So can you tease that out to say that virus infection actually did that? We don't know. It can cause pericardial inflammation. And truth be told, in young men, the mRNA vaccine can also lead to pericardial inflammation. So that has to be admitted and stated, and it's a risk. However, SARS-CoV-2 long COVID and SARS-CoV-2 infection can inflame the pericardium of the heart. So the heart is not immune to it. And we have had cases where someone had what we call cardiac tamponade, because they had a liter of fluid around the heart that squished the heart, and we had to drain it in the ICU in order to help them survive. So that is something that can happen to the heart. Now, as far as the heart attack per se, we don't know for a fact, although there is data suggesting that, but it's not a conclusive fact.
Yeah, it's hard to attribute everything that happens to a preceding COVID infection, but there's a lot of evidence that COVID, and there's increasing evidence that COVID infection illness can cause many things, including autoimmune disorders, et cetera. So should people with new conditions or potential or diagnosis of long COVID, should everyone get Paxlovid? How do we decide that?
So there's an ongoing study. We are a trial site along with a site in Phoenix, which is also part of the University of Arizona. It's part of the Recover trials. It's called the Recover Vital Study. And people would get either Paxlovid or placebo. And that study is ongoing. And we don't know the results. We're blinded.
We don't know.
But we are part of 50 sites across the country that are doing that. And there's also the Recover Neuro, and this is for people with brain fog, where they either get neurocognitive rehabilitation, where they're playing video games that are trained to make the brain, which is a muscle as well, to make it exercise and make it work better. So neurocognitive rehabilitation, plus or minus, with or without transcranial direct current, where they get a patch put on their brain, connect to a battery source that transmits direct current right through the brain. And there's some data to show that it helps improve cognition in people with Alzheimer's and stroke-related cognitive decline. And so that is being used in people with long COVID-related brain fog. And of course, the placebo group is essentially they get a patch which just tingles, or they get some sham neurocognitive rehab that's not really meant to improve their brain functioning, so that we can actually test to see if this is a real thing. Is this treatment is something going to work? While we're doing that, we are banking blood samples because these are well-defined people with long COVID. And the reason why we're doing that is to see if that future biomarker, something that we can find that can diagnose these people, we can retroactively go and confirm and verify against the ground truth as to whether this is indeed a true biomarker for long COVID. So we're trying to build a plane as we're flying it. We're trying to do the treatment while we're also figuring out the biomarkers, and also biomarkers that are in the pathway for disease creation. In other words, like the proteins and the platelet clumps that you were talking about that can increase the risk of clot formation, which could be the reason for the long COVID manifestation. Are they elevated? And in the case where they're elevated, are those the ones who respond to the treatment, as opposed to where it's not elevated, where even though they have long COVID for a different reason due to autoantibodies, are they the ones who won't respond to the treatment? So the biomarker, it can be both a signal for diagnosing, but it can also be a biomarker to tell us whether is this person going to respond to this treatment or that treatment. Because if someone has elevated amount of autoantibodies, they would respond better to anti-inflammatory therapies. If someone has elevated amount of virus particles, with evidence that the virus is sitting somewhere, they're going to be more likely to respond to Paxlovid. And so, and if someone has these blood proteins that are related to clotting, they're more likely to respond to blood thinners. So we foresee that there will be a panel of biomarkers, that any one of those biomarkers or a combination thereof can diagnose long COVID. There's not going to be, we think, a single biomarker. It's going to be a panel that will also inform precision medicine. So what are the treatments we can come to bear, because it speaks to the reason why they developed the long COVID in the first place.
1 year, 2 years, 3 years, evolving.
The goal is
when's
1
the
year.
earliest? 1 year. Okay.
The goal is 1 year. The recurrent neuro started fall of last year. Like I said, we are the only way we're going to know these answers. The only way we're going to know these answers is with people volunteering, participating in the study.
So let's, and thank you for that. So that RECOVER study, national, is that NIH funded?
Yes.
Am I correct in that? And Arizona, a collaboration in Arizona has been part of that. You've been the co-PI or the PI for a lot of this work, and we thank you for that and continue in the work for that. Suppose our clinicians watching and they say, this is great, I've got specific questions. Is there a follow-up? I actually know the answer to this, but is there a peer advice line that folks can contact? Do you want to share that information about people ask questions about folks they're taking care of?
Yes, there is a peer-to-peer support line, as well as there are 96 symptoms. Someone wanted to know what are the 96 symptoms. Is it possible, Mark, for me to share this that would be posted on a website, so that, or is that something you would want at this point in time?
Oh, we can. Do you mean share now? We're happy to send out, by the way, I wasn't scrolling down on the questions, so I have to catch up with some of these great questions. We can send this out to our participants as well, but is there something you wanted to share right now, or put a link in, or?
Yes, there is a 800 number. It's 844-844-3004. If people call.
Hey, Jen, Hey, Jen, would you mind repeating the number? And Jen, could you type it in there so that I don't mistype it into the chat for people for the peer support line?
It's 844-844-3004. People can call that number and leave a voicemail. That is one, way that people can actually, reach us. In terms of the
And those
other,
are for clinicians to get advice from your team, specifically about management. Is that
correct.
okay?
And we will get them to the right place. We also have a number which is for peer-to-peer support for patients, which is 520-542-2970. Because we find that oftentimes there are people who are, are really distressed by the fact that some even physicians say that this is something that exists in your head. This is your imagination, and in that particular situation, people feel deserted by the medical community, and they need to know that they're not alone. And so we offer a different kind of peer-to-peer where it's patient-to-patient support line, and that's the one which is the 520-542-2970.
Yeah.
But even if people call the wrong number, we can get them into the right place. And then we have a phone number for people who are interested in participating in the clinical trials. And there, as I mentioned, there are 2 clinical trials going on right now, but there's soon going to be a Recover Sleep trial that is for people who have sleep problems that is due to long COVID. And then a Recover Energize that will start soon after in May, which is for people with shortness of breath and respiratory problems. So the phone number for referring participants or patients to the clinical trials, as well as for referring for patients to self-refer themselves to clinical trials, that one is 520-626-5287. That's 520-626-5287. So there are 3 numbers, one for providers to actually use it as a warm line to be able to talk to folks, and the other to experts. The other one is for people, patients who are seeking to talk to trained peers who can literally, talk to them about why they're not alone and where are the long COVID clinics. How can they get help for their long COVID from a research standpoint and get them to the research studies? How can they apply for disability and help them direct them to resources where they can actually look for disability benefits and get some of their social determinants of health related issues addressed.
Thanks, Ed. These are really important resources, and we should have started the hour with those. So my apologies for not doing that sooner. We put the information in the chat. If you have any questions accessing that, you're welcome to follow up with me, with us. We're happy to get you links and information about doing that. So we have only a few minutes left, a bunch of questions. So maybe we're going to do a quick round, a very quick round robin of a few different questions. So I'm going to ask you questions, maybe try to keep the answer as short as possible, even though the questions are not going to be easy ones necessarily, but we'll do the best we can in the next few minutes. I'm sure we could have scheduled another hour for this, and maybe should again in the near future. Paxlovid, a lot of talk about adverse events and rebound. What's fact on that?
Yeah, no, Paxlovid rebound is a thing, but it doesn't mean that they are, people that need to, it is some thing that happens in individuals when they finish the 5th dose, and they can have a rebound of the symptoms. Right now, weirdly, we're not recommending that people isolate We don't think they're infectious at that time. There's more of an inflammatory rebound, and yes, there may be virus load, but right now, as you know, the CDC recommendation is continuing to shrink. That 5 days of isolation is enough if someone has an infection, and it's shrinking even further in terms of the length of time. So there is the rebound, but it is not tantamount to some adverse event that requires medical attention at this point in time.
Thanks.
Yeah,
And
the caveat is people are immunocompromised. And those people, that may not be a rebound. It may just be that their COVID is worsening after maybe a momentary improvement, despite the fact that they took Paxlovid. They should definitely seek attention. Regardless, if someone has rebound, they should talk to their physician so that in their individual case-by-case basis, the physician can do the right thing and give them the right advice.
yeah, so it's not a reason not to take Paxlovid. How many courses of Paxlovid can someone have in a year?
We don't have a number. There isn't a limit, but we are hoping that people aren't getting more than 3 infections in a year. We do know that people with long COVID are at increased risk for repeat infections. So all the more reason that they should take Paxlovid so that reduce the risk for developing long COVID and therefore reduce the risk for developing reinfections and get vaccinated.
So I had COVID 6 months ago, 4 months ago. I have it again. I got Paxlovid then. I qualify again now. I should get it again now.
Yeah.
And then still after 60 days, a vaccine is appropriate because I like not to get it a next time. Okay. How about where do you think things are going with monoclonals and metformin? Does that look promising?
Yeah, there's been lots of promising data on metformin. And also some of it comes from some data showing that informatics-based data showing metformin, people who are taking metformin were less likely to develop long COVID when they got SARS-CoV-2 infection. But that isn't the same as giving metformin for long COVID. But there are, small studies showing that that is indeed the case because of the concern that it's a mitochondrial disease, that long COVID is a mitochondrial disease, and metformin is actually good for the mitochondria. And so that is true. Now, as far as monoclonal antibodies, there isn't any data to suggest that it is helpful, but I know that there are ongoing monoclonal antibody infusions, studies, trials. There was one that was ongoing in our neck of the woods in Arizona, and there were sites both up in Phoenix area and Tucson. I don't know the outcome of that particular study. I don't think it's currently ongoing, but I know that studies are being done.
Well, we certainly have more to learn. The good news is that we continue to learn. There are important studies to differentiate moving forward. And there's evidence we already have in terms of treatment and resources for people to connect to. It doesn't put us in a perfect situation, but it puts us in a better situation, perhaps, than where we've been. I've seen some interesting publications around serotonin levels in people that are being measured. So there's much for us to learn moving forward. But maybe we should close with where we began, which is we need to keep our eyes on this together, share the resources and information as best we can, which is why we're so grateful for you being with us today, and engage in the response. We're really fortunate in Arizona to have great healthcare delivery systems, excellent universities, and the 3 universities collaborating together on the Community Engagement Alliance on research related to the RECOVER trial. And Sai, your expertise and your kind and compassionate leadership. So I want to thank you for that, and your team for all the great work that you have done and you continue to do in this space. And thank you for reminding us that we have to keep our eyes on this. And let's close with one last question for you, if I may. Sai, what makes you most hopeful moving forward related to long COVID?
I think it's people like you and events like this, Mark, that we need to keep the eye on the ball. Too often we go with the news cycle of what is hot and what is not, and perseverance is something that's vastly undervalued in some ways, in some areas, and This is the health of our communities, of our nation, and we need to keep the eye on the ball. And I did want to say that I think there was a mother who had made a comment about her 23-year-old son needing help and attention, and finding long COVID clinics is to support these long COVID clinics. And for this particular parent, any one of those three numbers, if you call them, we will make sure that your son gets seen by a small collection of physicians who are experts in this area. As Mark, you alluded to, we have our team. We know who are the people who are familiar with that, and we will make sure that these people in need get to the right place. And for that, unfortunately, this is cliche, but we need not only the attention of the people in the community and the people who are in healthcare systems, but the community at large, so that, when there are initiatives, there was a recent congressional, hearing from patients and their caregivers and their advocates, as well as from researchers and experts. But it was, woefully attended by a handful of senators. And so even they seem to be taking the eye off the ball. They should be monitoring the situation and making sure that this is being supported. We can't do it without, the support of some of this funding that you alluded to earlier. We can't do that without the support of the communities at large that are understanding of the importance of this and being community minded. And if it doesn't affect our family, that doesn't mean it's not important. It is important because it affects the community at large, and remembering that we are part of the community in raising this and fighting for resources and advocating for it, so that we can have the ability to prevent this from happening again, but most importantly, take care of the people, because we don't leave anyone behind, and we want to make sure that they're taken care of.
So that's just a beautiful summation of our collective work and commitment moving forward, and the compassion that you bring to this, the resources we have in the state, and where we're heading and growing our knowledge. And I appreciate you acknowledging that question from one of the participants, and please do follow up. I know that Dr. Parthasarathy is amazing, and his team are amazing in their commitment to caring for folks and advancing what we know and what we're able to do together moving forward. So Sai, thank you so much for being with us today. Thank you for everyone for joining. Jen has brought up on the screen, if you're able to see the screen, a QR code you can use to go to complete a survey for ongoing continuing education credits. In March, we're fortunate to have Dr. Steve Swenson from Mayo with us on Leading with Kindness. And Dr. Terry Pipe will be with us on human flourishing in April. We can certainly come back and revisit with you, Sai, as needed, share information, but let's continue to work together, share what we know, and support each other. Sai, thank you again. Be well, everyone. We'll see you at the next edition of Arizona Community Grand Rounds. Bye now.
Thank you.